Bismillah ar-Rahman ar-Rahim. Today we are going to talk about shock. The goals of this lecture is to know the definition of shock, different types of shock, and the management of each type of shock. Shock is defined by inadequate tissue perfusion and oxygenation, and this leads to cellular dysfunction and damage, and subsequently it will cause organ dysfunction and damage. So, if the heart does not able to push the sufficient amount of blood to perfuse different organs, or if the blood vessels themselves are extremely dilated to accommodate the blood volume, or if there is no sufficient blood volume inside the circulation, or there is an obstruction of the circulation, all of these reasons will lead eventually to stoppage of the tissue perfusion and failure of oxygen delivery to different cells. So we have different types of shock according to the etiology of this shock. If the problem is inside the heart, as the inability of the heart to pump sufficient amount of blood carrying oxygen and different nutrients to the tissues, it will be a cardiogenic shock. Or in another terms, this is heart failure, but it's a prominent heart failure up to shock stage. And if there is no sufficient intravascular blood volume to be pushed inside the blood vessels to the different tissues, it will be the hypovolemic shock, like in cases of severe bleeding or severe dehydration. Or if there is an obstruction inside the circulation itself, which is preventing the flow of the blood inside the cardiovascular circulation, it will be the obstructive shock, like in the massive pulmonary embolism or intention pneumothorax. And the last type of shock is the distributive shock. In this type of shock, there is sufficient amount of the blood volume and the heart is pumping efficiently, but the problem is in the extreme and severe vasodilatation of the blood vessels to the extent that the intravascular blood volume is not sufficient to fill this circulation. As we said in cardiogenic shock, it's caused due to inability of the heart to pump sufficient amount of the blood to the tissues. And the cause of this shock can be, number one, arrhythmias like ventricular fibrillation or pulseless ventricular tachycardia. Number two is valvular lesion like severe aortic stenosis or severe mitral stenosis. Number three, it's myocardial injury happening in acute myocardial infarction in patient suffering from ischemic heart disease. Number four is hypertrophic cardiomyopathy, and different types of cardiomyopathy in severe forms can lead to cardiogenic shock. In this slide, we can see the pathophysiology of the cardiogenic shock. Due to decreased myocardial contractility or arrhythmias, or any cause of cardiomyopathy, there is a severe reduction in the cardiac output, which is normally 5 to 6 liters per minute in a normal person. But in a cardiogenic shock, it's much less than this. So, due to inability of the heart to pump the blood will be accumulated in the venous system, causing an increase in the venous pressure, which will lead to tissue extravasation and edema, especially in the lungs, causing pulmonary edema. At the same time, there is sympathetic overactivity in a trial to maintain normal blood pressure. But despite this normal blood pressure, the organs are still poorly perfused due to the severe reduction in the blood flow. So the patients with a cardiogenic shock will be presented with distended jugular veins due to increased venous pressure. Number two is hypotension. Number three is weak pulses. Number four is arrhythmias, which is usually tachycardic arrhythmias. At the same time, there will be pulmonary congestion or pulmonary edema that can be heard over the lung zones as lung crackles or capitations. In the second type of shock, which is the hypovolemic shock, in this type of shock, the etiology is totally different. We have normal heart that can pump sufficient amount of the blood, and we have normal tone in the blood vessels, and there is no obstruction to the blood flow. But the problem is that we do not have a sufficient intravascular volume. So the reduced circulating blood volume will lead to decrease in the cardiac output. And the etiology of the hypovolemic shock can be acute severe hemorrhage, severe vomiting or diarrhea, severe dehydration, extensive burns, severe peritonitis or pancreatitis with insufficient fluid resuscitation. All this etiology will lead at the end to a severe reduction in the amount of the intravascular volume, causing the hypovolemic shock and inadequate tissue perfusion. The presentation of the hypovolemic shock, starting from the left upper corner, neurologically, there will be an altered mental status. First, it will be restlessness. Then it will progress to disorientation. And in severe cases, there will be severe lethargy up to loss of consciousness. Regarding the cardiovascular circulation, there will be tachycardia and there will be weak pulse. It's the rapid thready pulse. And the patient will suffer from dyspnea due to lack of the red blood cells which carry the oxygen. And regarding the kidney, we will have severe reduction in the urinary output due to decrease in the amount of the intravascular volume. The extremities, the upper limbs and lower limbs will be cool and clammy skin due to blood loss. Sometimes we will have obvious external cause of bleeding, like penetrating stabs in the femoral area or in the chest or in the abdomen. And hypotension, drop in the blood pressure, and this is due to decreased in the amount of the circulating volume. So we have to manage this patient by rapid fluid administration intravenously till the blood becomes available. Then we will give the patient blood as soon as it is available. Is the presentation of patient with a hypovolemic shock. The patient will be hypotensive with a rapid shallow breathing due to sympathetic stimulation and acidosis. He will have a rapid weak pulse with flat neck veins. It is not congested like in patients with a cardiogenic shock. And at the same time, there is cool cyanotic extremities due to severe vasoconstriction and hypothermia due to decreased perfusion with dry mucous membranes like in the mouth, with severe reduction in the urinary volume. The third type of shock is the distributive shock. In this type of shock, we have normal cardiac contraction, normal heart pumping ability, and we have sufficient or normal blood volume. We do not have dehydration, we do not have loss of the intravascular volume. But the problem is in the severe vasodilatation in the venous and the arterial circulation. With adequate fluid therapy, the heart usually compensates by increasing the heart rate and contractility, although this might not be enough. The vessels dilate, causing relative hypovolemia with severe reduction in the systemic vascular resistance. Changes above lead to reduction in the blood pressure and reduction in the tissue perfusion. Sometimes there is capillary leak that will worsen the condition and causing escape of the fluids from the circulation to the blood vessels, to the tissues, leading to edema, including pulmonary edema. Distributive shock. The first type of distributive shock is the neurogenic shock, and this is due to sudden, grievous situation, painful stimuli, severe anxiety, prolonged standing in the upright position, etc. And it is manifested by fainting with bradycardia. Number two, the septic shock. And this is one of the most commonly seen type of shock in the intensive care units. In this type of shock, it results from severe systemic infections, usually gram-negative bacteria, or their toxins is the etiology of the septic shock. Typically, sepsis is manifested by hyperdynamic circulation. So we will have tachycardia, we will have increased cardiac output, but severe vasodilatation with subsequent decreased cardiac filling pressure and severe reduction in the peripheral vascular resistance with, as we said, there will be increase in the cardiac output. But despite of the increased cardiac output, there is insufficient tissue perfusion due to the severe vasodilatation of the circulation. This increased cardiac output is caused by the excessive stimulation of the sympathetic system in these patients. Number three, the anaphylactic shock. It's a type of a distributive shock, but it's caused by drugs, insect bites, foods, and different allergens can cause anaphylaxis up to anaphylactic shock. And in this type of shock, it is characterized by skin manifestations like pruritus, urticaria, angioedema, and also there will be severe respiratory distress, either due to laryngeal spasm caused by severe extensive laryngeal edema, or there will be severe bronchospasm. At the same time, we will have hypotension and inadequate tissue perfusion. Sometimes the patient have abdominal cramps and diarrhea. In this type of shock, there is no abnormalities in the cardiac functions like in the cardiogenic shock. There is sufficient amount of the blood volume and there is no decreased amount of circulating blood volume as in hypovolemic shock, and there is no severe vasodilatation in the arteriovenous systems occurring in the distributive shock. But the problem is in the obstructive shock is an obstruction to the flow of the blood outside the heart. This obstruction will stop or decrease the flow in the cardiovascular circuit. This can be caused by, number one, is the cardiac tamponade and severe constrictive pericarditis, which will directly impair the diastolic filling of the right ventricle. Also, tension pneumothorax or intrathoracic big tumors can indirectly impair the right ventricular filling by obstruction of the venous return to the heart. Also, massive pulmonary embolism obstructing more than 50% of the pulmonary vascular bed will obstruct the flow in the cardiovascular circulation. All of these etiologies will stop or significantly decrease the flow of the blood in the cardiovascular circuit, leading to inadequate tissue perfusion and shock stage. We will compare some important hemodynamic parameters in different types of shock. Number one is the preload, which is the amount of the blood present in the venous side of the heart and this can be assessed by the pulmonary capillary wedge pressure measured by Swan-Ganz catheters or the central venous pressure. The second parameter is the cardiac output. The third one is the afterload and the systemic vascular resistance, which is the tone inside the blood vessels. The fourth parameter is the mixed venous oxygen saturation, reflecting the tissue perfusion. In hypovolemic shock, we will have decreased pulmonary capillary wedge pressure and central venous pressure due to decrease in the amount of the effective intravascular volume. And we will have decreased cardiac output. But the systemic vascular resistance is increased due to increased sympathetic activity. But the mixed venous oxygen saturation is low due to poor tissue perfusion caused by the reduced cardiac output. In cardiogenic shock, we will have increased preloads. We will have increase in the pulmonary capillary wedge pressure and in the central venous pressure due to accumulation of the blood in the venous side of the circulation, due to inability of the heart to pump this blood. We will have decreased cardiac output due to impaired pump function, but the afterload and the systemic vascular resistance is increased due to sympathetic activity, and at the end we will have poor tissue perfusion and decreased mixed venous oxygen saturation. In distributive shock, we will have decreased or normal filling pressures, normal central venous pressure or pulmonary capillary wedge pressure, or decreased, but we will have increased cardiac output with a decrease in the systemic vascular resistance. And the mixed venous oxygen saturation will be either normal or even increased. The problem in the distributive shock is the severe vasodilatation in the cardiovascular circuit. In obstructive shock, we will have increased preload with increased pulmonary capillary wedge pressure and central venous pressure. We will have severe reduction in the cardiac output. We will have normal or increased systemic vascular resistance due to sympathetic overactivity. And at the end, we will have tissue hypoperfusion with decreased mixed venous oxygen saturation. Goals of the treatment. We have to manage and treat patients presented with shock in an ABCDE order. A stands for the airway. We have to maintain a clear, patent airway. B for the breathing. We have to control the breathing. C is the circulation. We have to optimize the circulation either by inotropes, fluids, or vasopressors. D is to assure adequate oxygen delivery. And E is to achieve endpoints of the resuscitation. Management of shock, it should be directed to the etiology of shock itself. So if we have dehydration, we should give lots of fluids. If we have bleeding, we must stop bleeding. If there is an obstruction to the flow like intention pneumothorax or cardiac tamponade, we have to drain the cardiac tamponade. We have to drain the tension pneumothorax to relieve the tension pneumothorax. If there is severe sepsis, we have to treat the pathogen of the sepsis. In anaphylactic shock, we have to remove the allergen causing the anaphylactic shock, and etc. The base of the management is directed to the etiology itself. Then we have goals that we should maintain in dealing with patients with shock. Number one, we have to maintain a mean arterial blood pressure of 60 millimeter mercury. We have to maintain the oxygen saturation more than 92% or even 95%. We can use the mechanical ventilation if it is necessary. So how can we maintain mean arterial blood pressure and correct the hypotension? This should be done by intravenous fluid, normal saline. Give normal saline to any patient hypotensive. And if the hypotension exists, we have to give more intravenous fluids, except in patients with cardiogenic shock. We shouldn't give them lots of fluids, as the problem in this patient is increased venous pressures and tissue edema and pulmonary edema. So excessive fluids might worsen the pulmonary edema in cardiogenic shock. In patients with a hypovolemic shock due to bleeding, we should give them blood as soon as we can. After giving the IV fluids or blood, if the hypotension persists, we can use the vasopressors and inotropic agents to maintain normal blood vessels. Up to intra-aortic balloon pump can be used in patients with a cardiogenic shock. Management of cardiogenic shock. Number one, we have to give oxygen. We have to maintain an adequate IV line. In patients presented with acute myocardial infarction, we have to give them narcotic analgesics like morphine 10 mg for chest pain relief. Inotropes and vasopressors also can be given in the management of shock, like dopamine from 3 to 10 or up to 20 mic per kg per minute. Noradrenaline can be used. Dobutamine also can be used. Defibrillation is done to the cardiogenic shock patients presented with ventricular fibrillation or pulseless ventricular tachycardia or hemodynamically unstable atrial fibrillation. And management of the hypovolemic shock, you have to maintain a clear patent airway and be sure that the patient is breathing well. If not, intubate and mechanically ventilate. We have to stop the apparent source of bleeding if possible. We have to give large amount of IV fluids and insert big peripheral IV cannulas to give lots amount of IV fluids in order to maintain the effective intravascular volume. We can give crystallite fluids till the blood and blood products are available to maintain the mean arterial blood pressure. Management of patient with neurogenic shock is simply to raise the foot end of the bed, or if the patient is lying on the floor, we have to elevate patient's leg. Management of the septic shock. Septic shock should be managed in ABCD order. We have to maintain a clear patent airway as in all shocked patients. We have to maintain the breathing with normal oxygen saturation more than 95%. If the patient cannot maintain this saturation by its own respiration, we have to intubate and mechanically ventilate the patient. We have to resuscitate the patient with a lot of intravenous crystalline fluids. And we have to monitor the urinary output and the hemodynamics very closely. At the same time, we should have cultures from the patient to diagnose the septic shock and to define the appropriate antibiotic that can be used. Until appearance of the cultures, we can give broad-spectrum antibiotics to combat the infection. Patients with anaphylactic shock. Patients presented with severe life-threatening anaphylactic shock, they should be treated in an APC order. Number one, we have to maintain a clear patent airway, and we have to monitor and observe the patient's breathing to maintain the oxygen saturation above 95%. In case of failure of maintaining a clear patent airway, or in severe bronchospasm and inability to maintain the oxygenation of the patient, we have to intubate and mechanically ventilate the patient. Regarding the circulation, we have to insert white poor peripheral IV lines, we have to give at least 1 to 2 liters of crystalloids, but the most important is that we have to give epinephrine immediately once the diagnosis of anaphylactic shock is confirmed. If we do not have an IV line, we can give epinephrine subcutaneously or intramuscularly till the IV line is secured. We can use also vasopressors and steroids and antihistaminic in the management of anaphylactic shock.